Ever wondered how premature babies start breathing when their lungs can't make surfactant yet? Let's break it down simply. Surfactant replacement therapy in neonate. What is lung surfactant? Surfactant is a surface tension lowering agent, composed of substances including phospholipid, neutral lipid, and protein, secreted from tight 2 alveolar pneumocyte. Begins production around 24 weeks of gestation, with significant increase after 34 weeks. Functions of surfactant: decrease the surface tension, promotes lung expansion during inspiration, prevents alveolar collapse and loss of lung volume at the end of expiration. Indication of surfactant replacement therapy: respiratory distress syndrome, mechanism aspiration syndrome, pulmonary hemorrhage, severe respiratory syncytial virus-induced respiratory failure, pneumonia and sepsis, persistent pulmonary hypertension of the newborn. Contraindications for surfactant replacement therapy: active pulmonary hemorrhage, congenital diaphragmatic hernia, hemodynamic instability, lung maturity present. Surfactant preparations: natural surfactants of animal origin, Surfactant, which is marketed under the brand name Surfactant, Bovactant, Alveofac, Poractant Alpha Corosurf, Cafactant, Infasurf. Synthetic surfactants: Lucinactant, Surfactant- less used due to lower efficacy compared to natural types. Surfactant Survanta. Dose 100 mg/kg/ dose 4 ml/kg. Prophylaxis: 100 mg within 15 minutes of birth. Up to 4 doses during the first 48 hours of life. Maximum frequency: every 6 hours. Treatment: 100 mg within 8 hours of birth. Up to 4 doses during the first 48 hours of life. Maximum frequency: every 6 hours. Bovactant, which is marketed under the name of Alveofac. Dose 50 mg/kg/ dose 1.2 ml/kg. Administration techniques: surfactant is administered when the infant is lying supine. Positional maneuvers are not indicated. Techniques: Ensure method: intubate, surfactant, extubate. LISA, less invasive surfactant administration, method. MIST, minimally invasive surfactant treatment, method. Traditional endotracheal installation. Aerosolized surfactant under research. Ensure, intubate, surfactant, extubate, to CPAP technique. Mechanical ventilation can be avoided by using this technique when surfactant is administered. This has reduced the need for mechanical ventilation and development of bronchopulmonary dysplasia, chronic lung disease in randomized trials. Immediate or early extubation to non-invasive respiratory support CPAP following surfactant administration should be considered in otherwise stable infants. LISA, less invasive surfactant administration, method. In this method, a thin flexible catheter 5 FN hole catheter, which is inserted into the trachea using manual forceps. Surfactant is administered while the spontaneously breathing infant is on nasal CPAP. Monitoring during surfactant replacement therapy: proper placement and position of delivery device and endotracheal tube. Reflux of surfactant into et tube. Red sounds. Chest wall movement. Vital signs: SpO2 by pulse oximeter. Arterial blood gas analysis. Chest X-ray. Early effects of surfactant therapy include a reduction of SpO2, need and improved partial pressure of oxygen and partial pressure of carbon dioxide, NO ratio. Likewise, improved VT and compliance should be noted with improved lung function and decreased ventilator PIPs. Long-term effects should result in decreased necessity for mechanical ventilation and less severe chronic lung disease of infancy. Complications of patent ductus arteriosus, necrotizing enterocolitis, and intraventricular hemorrhage have not been significantly influenced by surfactant therapy to date. Side effects: small risk of pulmonary hemorrhage, secondary pulmonary infections, air leak, pneumothorax. Surfactant therapy for diseases other than RDS: pneumonia, mechanism aspiration syndrome, persistent pulmonary hypertension, pulmonary hemorrhage, acute respiratory distress syndrome (ARDS). If this helped you understand surfactant therapy, give it a like and subscribe for more simple medical explanations.